Thank you, Paul. Welcome. I want to first acknowledge Paul and all his efforts to put this together, and appreciate everyone's willingness to come and tonight to be party to it. Tonight's symposium is on the rotator cuff. It's going to be certainly one of the most central areas as to why rehabilitative therapy, physical therapy, is essential in the shoulder. I mean, it's essential for all aspects, but mainly because all aspects of shoulders involve rotator cuff to some extent. It can be instability, total shoulder replacement, fracture. It all comes down to the cuff and cuff functioning. So this is about cuff and cuff functioning primarily as an anatomic issue. All right. So first off, and a couple of these slides are a little bit different than what you have there. The way I'm going to put this together is, Paul said I'm going to talk about pathoanatomy of rotator cuff tears and surgical approaches, and he failed to mention that I also tend to wax poetic about the shoulder a little bit, because I think the shoulder is pretty interesting. It's unique, and for those of you who have had a chance to do much physical therapy with it, I think you'll hopefully try to connect some dots tonight as to why it can be challenging and why that which you do is so centrally important. First, the shoulder is unique in the human body, and it has a bilaminar construct of muscles, two layers of muscles. The outer muscles, the muscles that we see, the deltoid, trapezius, pectoralis, the power muscles, the drivers, that which generates force and production of effort. But then there's an inner layer of muscles. That's the rotator cuff. The shoulder is designed, it has more motion than any other joint in the body for the very purpose of taking advantage of our prehensile thumb. You need to position the hand in space. The capacity of the shoulder joint, if you take the ligaments in the shoulder, they are naturally lax, which means if you would blow the shoulder up like a balloon with water in it, the shoulder has the volume naturally to contain two humeral heads. So that's why the shoulder has so much range of motion potential. So the ligaments only get tight and taut at in range of motion. So controlling all this central range of motion is largely the function of the cuff. Now there's some surface issues, and the glenolateral construct is important because there's some concavity there. But the cuff is centrally important. And as you all know before review, so anteriorly here be the subscapularis, which covers the front of the shoulder. The biceps tendon is missing, which is an important part of the shoulder, not so much in terms of a head depressor or function, but it's more kinesthetic. I think the biceps is more of an elbow muscle. The important thing in the biceps and the shoulder, we'll get later, is it is a wicked pain generator. And it generates a pain pattern that's just like cuff. So many times these are admixed, or they can be confused with one another. Then the posterior shoulder, the infraspinatus and teres minor, and together they create a hood. I think that whoever coined the rotator cuff anatomically would be better called a rotator hood, because it is a collective of tendons. If I were to show you, if you were to look at the time of surgery and see, you would see a confluent white tendon strip. You say, which one is supraspinatus? Well, supraspinatus sort of goes from here to here, and infraspinatus goes from here to here. So they are they're in continuity. The shoulder functions with ball and socket kinematics, just like the hip. So, which means if you put a dot in the middle of the humeral head and move your shoulder through a range of motion, that dot should not move more than about 1 millimeter. So the shoulder natural movement is all rotational. It's not translational. Now, there's some coupled motions at end range, 1 to 2 millimeters maybe. But if the shoulder moves abnormally, it's translational in nature. If it moves abnormally anteriorly, it's anterior instability, subluxation. If it moves too abnormal posteriorly, it's posterior instability. If it tries to move too abnormal superiorly, well, you say, well, it can't. Well, it can try. I mean, the acromion's going to block it, and the supraspinatus is there, but that is impingement. So when the humeral head isn't contained well in the glenolateral socket and it wants to move superiorly, that's what is the essence of mechanical impingement. The rotator cuff, these are from some cadaveric studies, and here's a specimen in which the humeral head, that's the biceps tendon, and this would be the subscapularis muscle. And these are all separated out for the picture, but supraspinatus, infraspinatus, teres minor. But there's a way to calculate potential force by cross-sectional area and weights and all that. This has been done in a number of cadaveric studies. That the force generation of the rotator cuff is balanced anterior to posterior across the biceps. So which means the subscapular, in terms of ability to generate force, which means larger, it means size. The subscapularis equals supraspinatus, infraspinatus, teres minor combined. So we start talking about force couples in the shoulder, because the way the rotator cuff works is that the anterior cuff, posterior cuff work together, result in vector compression. That's stability. So we talk about, so sometimes when you're dealing as a therapist with weakness and the rotator cuff needs to be strengthened, it may be that you're dealing with imbalance, because typically the internal rotators are about 3-2 stronger than external rotators, which means the internal rotators of the shoulder, subscapularis, pectoralis, and latissimus, powerful internal rotators. They can easily overwhelm the external rotators, which is really cuff, posterior deltoid a little bit. So a lot of time what you're dealing with is imbalance. But this is the biomechanical, biological rationale when you hear of balanced force couples in the shoulder, because it is balanced across the biceps. So you have these balanced force couples, this cuff, this effort to try to keep the humeral head centered in the glenolateral socket, and then the shoulder functions the way God intended, the way our evolution is intended. And the purpose of the shoulder is to take advantage of one of the most important evolutionary advantages, probably second to the big brain. I mean, the Homo sapiens, the big brain and the prefrontal lobes and all that are obviously the most important. But functionally, it's the prehensile thumb. It really separates us from all else. And ability to use weapons and maybe I should use that one first. But building and throwing and things like that, functional activities. So the shoulder is designed to position this hand in space. So you have all this structure for the shoulder, and the problem is when it raises the hand in space, it can potentially pinch. So here's the humerus here, and this would be like the acromion over the top. And when this thing rotates up, it shoves the supraspinatus, maybe biceps area, under the greater tuberosity, which is a little bit prominent, into the acromion, or has the potential to. That's what impingement is. So the shoulder is designed to be an impinging machine. And much of why so many of the shoulder pathologies have cuff involved is that anything in the shoulder that distorts its motion, strength, or anything will bring the rotator cuff into play. So, someone who has some instability will also have some bursitis and impingement. Why? Because the cuff is dysfunctional a little bit. Does that mean the cuff needs to be treated? Well, you can treat the cuff, and you can try, cinema physical therapy, rehab, strengthening, and maybe you can control the instability. But the cuff dysfunction is the secondary phenomenon. Just like frozen shoulder. The central problem is a stiffness in the shoulder. Yeah, the cuff's painful, and yeah, it's sore, and yeah, they have some weakness. But if you focus strengthening and leave that motion unaddressed, they may get some better, but they're not going to be solved. So the function of the rotator cuff is to stabilize the humeral head in the glenolateral socket. It's not really to initiate anything. It's not really to be a major force generator. Certainly rotational stuff is helpful as well, but it's mainly a force generator. And the problem is, you see in the subsequent slide, so the arm is like here, down at the side. Here's the humeral head at the side, and there's the deltoid, and there's the cuff. And so the cuff's going to work. The cuff's going to fire to create a stable glenolateral socket, a stable fulcrum, and then the deltoid is the one that raises the arm in space. But I mean, think about it for a moment. Look at the vector. The initial vector, when the arm's down here, of the deltoid firing is, if you don't have a stable pivot, that head goes up. The deltoid is pulling the head up unless the pivot is stable. Now, normally, you see the subacromial space. Well, it's not much of a space. I mean, there's a membrane in there called a bursa. So the way the shoulder anatomically is designed, it's like the piston engine in a car. It is fine tolerance, which means normally the rotator cuff and the acromion kind of barely touch. They glide past one another. So how much space is available? Not much. 3 millimeters. And that's why a lot of people, if you get a little bit of distortion in the bursa, a little bit of thickness, they have such audible noise, but it doesn't bother them. And if it doesn't bother them, I say, well, consider yourself fortunate that that doesn't bother you. But some people just have noisy shoulders. But that's why, because the bursa, if it gets a little bit bumpy, it can cause noise. Now, if the noise doesn't hurt, then the patients are fortunate. It's curious why it wouldn't hurt, because you know it's rough, and you know it could hurt. And usually when patients say it doesn't hurt, I don't try to over-explain the fact that it could hurt, because I'm concerned that I might sort of put a thought in their head that they're saying, well, now that you mentioned it, it is a little bit painful. So the extrinsic mechanisms of tendon injury, and we'll get later in the coracoacromial arch and all that, but you have this basic mechanism of the rotator cuff stabilizing the humeral head, the deltoid wanting to pull it up, and then as you'll see later, as we get older, everything it pulls it up into gets sharp and prickly as we get older. Bone spurs form. So when I think of category of rotator cuff tears, and so what we're talking about today is just rotator cuff tears. I mean, you can pick volumes. We can just, what I've just talked about in terms of the pathophysiology of cuff dysfunction and pain we could talk all night about it. But we're going to talk specifically about tears. Now, when I think of tears in sort of two categories. So we've talked about the anatomy and how the rotator cuff functions. But I think of tears in terms of, was the tendon previously normal and then it ruptured? Or was the tendon previously not normal and it ruptured or tore? Now, if the tendon was previously normal, something big has to happen to that shoulder. Because typically, normal tendons generally don't rupture. Not because they can't, it's because they're not the weakest link in a chain. If you have a shoulder that has a normal tendon and some perturbation is applied to it, something else is going to tear. So, the classic example, and I think it's a good example in the shoulder to understand age-related change, is someone falls and has an abduction external rotation injury mechanism. Okay? The shoulder is going to want to try to come out of joint. In a 20-year-old, what's the weak link? The weak link in the shoulder in a 20-year-old is the capsule and labrum. It's not that it's weak. It's just that the bone is hard and the tendons are great. So that mechanism, if something's going to distort at a 20-year-old, largely it's classic instability, labrum and capsule, ligaments. You take about a 50-year-old, okay, and the same injury mechanism. Now, the labrum and capsule could tear, but more commonly, the rotator cuff tears. Not because the labrum and capsule is suddenly not as strong at age 50. It's because by age of 50, the tendon isn't quite as strong. So it's basically, a chain tears at its weakest link. So by middle age, the tendons become more of a weak link. Now, that being said, if I have a 55-year-old patient who dislocates their shoulder and they tear their ligaments and their labrum, what I tell them is, one, it's statistically uncommon, and you've just torn your shoulder in a pattern of a 20-year-old. What does that mean? That means they got great tendons. That's what it means. And usually what that means is genetically it's a gift, and they're healthy. Now you take a 75-year-old, same injury mechanism. The cuff may tear, but more likely the bone breaks. Not that the cuff is any stronger at age 75 than 50. It's not. It's just that there's a precipitous decline of bone quality in the proximal humerus as you get older. So a lot of it's just a weak link in the chain. So it takes quite a bit to tear these tendons. And usually it's some sort of a traumatic dislocation. But usually operative treatment is needed, and that's not really what we're going to talk about too much tonight, because the more interesting topic, this might be 2%. The more interesting topic is to talk about the 98%. Here's the 98%. Tendon tear in a previously abnormal tendon, meaning it's degenerative. It can be degenerative from, and it can then tear with macrotrauma, meaning they could dislocate or fall in an outstretched arm or some major event. It can tear with microtrauma, consistent repetitive injurious stress, a mail handler, something with repetitive overhead activity, something like that. Or it can just tear. It can melt apart. The biology fails. And that's something more like, one of my 70-year-old patients who's been symptomatic and painful for 3 or 4 months, no history of trauma, not very active, thinking they have some bursitis, and I examined and said, my God, you got a rotator cuff tear. They have no idea when it happened and when it occurred, and that's more of an insidious, progressive, degenerative biologic failure. With the extrinsic component, it's all about impingement. I'm not sure how this projects, but here's an example of the rotator cuff here. The acromion is here. This is the back of the shoulder. The acromion's been cut out, but it shows the this would be more of the teres minor, teres minor, infraspinatus, supraspinatus up here, but it shows everything is in close apposition in here. There's no room of tolerance at all, and so you start creating some bone spurs or some partial tendon tears, or the bursa gets thickened. There's no room for anything like that. And when you do, you have mechanical impingement, extrinsic impingement. And then it's like grit. Once it gets in there, it can cause problems. Like some people, raise their arm up and it hurts and it grinds. Well, that grinding is the problem. Things are coarsely rubbing against one another. The intrinsic is the biologic. It's vascular. It's age-related. It's degenerative. The shoulder is not unique, but it's one of the archetypes in the human body in a study of planned senescent change, age-related change. The most common and obvious aspect would be your hair growing gray. As we all get older, at some point, you're going to get some gray hairs. What does that mean? It just means you're getting older. Some people get a lot, some people get a little, but everyone gets some. The shoulder, these tendons deteriorate as we get older as a consequence of biology. It just happens. Then you add that with some bone spurring, and that with some applied weakness as they get older if they haven't stayed in as much physical condition, and it's a recipe. It's fertile ground for cuff dysfunction and maybe tears. I'm going to talk to you about senescent change for a moment, because I think it's useful for you to understand it. Mainly, one, that you understand it, and two, that you can apply it to patients, because especially if many of you deal with patients, more senior patients, 55 and older, degenerative, especially 60s and 70 patients, they're going to have a lot of questions about spurs and all that. Senescence change in the body is a normal phenomenon of aging. It doesn't mean it has to hurt. And there are several things in the shoulder that are going predictable senescent change. First, the rotator cuff. Now, one thing I sort of have glossed over, but we talk about rotator cuff tears, and I keep saying tendon tears. The rotator cuff is a hood, and the subscapularis is in the front, supraspinatus sort of top, infraspinatus sort of posterior superior, and teres minor posteriorly. The shoulder in a degenerative always tears in the same pattern. It starts with the anterior. All degenerative tears in the shoulder start at the biceps aperture. So the supraspinatus tears from anterior to posterior. There are a few things that are predictable. That's predictable. So it tears from the bicep aperture posterior. So if it's a 2 centimeter tear, that means the 2 centimeters behind the biceps is torn. If it's a 4 centimeter tear, the 4 centimeters behind the biceps is torn. Now, there are some talk about, well, you can get isolated infraspinatus tears and all that. I'm not so sure. I mean, anything's possible, but that occurs very rarely. So the problem is, it's the superior tendon, the supraspinatus, and if the supraspinatus tendon tear gets bad enough, the infraspinatus starts to peel off too. It's like getting a big hole in your shirt, and eventually it keeps tearing. But it doesn't extend anteriorly. The subscapularis tendon does not really exhibit degenerative change. You can have trauma to it. So degenerative change is superior tendons to back. So the supraspinatus, so when I say rotator cuff tear, I should be saying in a forum like this, an educational forum, supraspinatus. But I'm lazy about it, and I call it rotator cuff. But we're talking about supraspinatus. Most tendons in the body might get weak, but they don't structurally change. The tendons in the shoulder tend to get fatty degeneration, which means the tenocytes change the matrix. The matrix changes in the shoulder of the tendon. It literally changes. Why? It's just the way it is. It's just planned senescent change. Here's an extreme example, which makes for a nice slide, is the supraspinatus tendon that I had to remove, but it's fatty. Historically, they said it was mucinous change. It's really fat. And the muscles in the shoulder, when tendons tear in the shoulder and they go untreated, the muscles atrophy. Well, they all atrophy. You can have a quadriceps tendon tear, and you can get quadriceps atrophy. Achilles tear. Gastrocnemius atrophy. But those muscles don't change into fat. Rotator cuff changes into fat. And that's a bad deal. That's irreversible. That's bad. I mean, if I have someone who's got a rotator cuff tear, and maybe it's fixable, or maybe I got some ideas on how to fix it, and there's significant fatty degeneration, it's a waste of surgical time. To think you're going to, because you are attempting to reattach a tendon, that muscle doesn't work. And what's the point? So MRI is very helpful for that. We're not going to talk about much tonight, although if you have some questions later, we can talk about MRIs. In the shoulder, I don't know how well these project, but here's the humeral head. The greater tuberosity starts getting all these little bumps and spurs here. The AC joint becomes radiographically arthritic. A lot of people, and if you've treated patients over 60, a lot of people come in and they'll have these little points and knobs over their AC joints. And if you would X-ray, you say, you got some AC arthritis. They do. And does it hurt? Not very commonly. And if anything, if the AC joint is a problem, it's because whatever superior osteophyte projection you see coming up, which they can feel, there's usually an analogous one going down. The ones that go down are a problem because they impinge on the rotator cuff, the supraspinatus. But the AC joint becomes arthritic. And someone says, well, yeah, my AC joint's arthritic, and what does that mean? I said, well, it means you're not 20 anymore. Now, but also means it's not biologically normal. It's not normal. I mean, it's not the way it was when you were 20. So all of a sudden, you have some age-related change, and you go out and do an activity, the AC joint might not be as tolerant of that activity. Maybe. But just because the AC joint's arthritic doesn't mean it's a bad thing. Bone spurs. Now, so everyone talks about bone spurs in the shoulder. So the acromion develops a hook on it as we get older. Now, this was a study done looking at young athletes, or college-age athletes. And so a acromion, so the bone on top of the supraspinatus, on top, the bony hood of the shoulder, if it's flat, it's generally called a type 1. And if it's really hooked, it's called a 3. And if it's not 1 or 3, it's a 2. It means 2 is kind of curved, somewhere in the middle. Young people generally don't have hooked acromions, 1%. As we get older, the bone forms in the coracoacromial ligament as like an enthesiophyte, which means bone forms as we get older, and the result is that a previously flat or curved acromial morphology is now hooked. And once it's hooked, it could be a problem. It might not. But you can imagine now, you're raising the arm up in space, the rotator cuff, you have something much more prominent to hit against. So that could be a problem. If the rotator cuff doesn't function properly, then this vector of the deltoid is going to drive that humeral head up. Now, this is an extreme example, but essentially that's what happens. And if it drives it up into a flat acromion, maybe it's not so bad. If it drives it up into a hooked acromion, that's not so good. So again, the compressive effect is not only rotator cuff strength, but balance across the biceps. Balance. Coacromial arch alterations can impact what we talked about, especially spurs. The other challenge, and this is a little aside if we're talking about before I get into surgery, but there's a myriad of shoulder girdle symptoms that are seen because the rotator cuff is the central functional element in the human shoulder, which means you're going to see cuff symptoms in nearly every human condition imaginable that affects the shoulder, whatever it is. And somehow, me as a physician, you as therapist, have to discern, are the cuff symptoms real? Yes. Do they hurt? Yes. Because many times why they have so much pain is the subacromial bursitis gets heated and angry, and they hurt at night. And usually night pain is what drives a lot of people to surgery anyway, to seek relief of it. But what it comes down to is that your rehab effort, most appropriately, is addressing the rotator cuff. But is the rotator cuff primarily involved, or is it secondarily involved? Either way, you got to address it. But part of it to discern is that, how does it play in the patient's symptoms? And sometimes it's not so easy to figure out, at least for me. So there's numerous pathologies, other tendon pathologies. There can be chronicity, there can be posture, there can be scapula. We don't have time to go into all that. But just because someone has rotator cuff symptoms doesn't mean their primary problem is rotator cuff. And how they interpret their symptoms. If everybody came in saying, well, where's, so the classic, something I can see from down the hall, my shoulder hurts when I reach or walk overhead. So, well, where does it hurt? It usually hurts right here. Sometimes it goes down to here. When I'm very active, it hurts at night. It's like, that's cuff. I'll go through the motions and try to, be sure it's not anything else. But that's classic. But what happens when they come in and they have a lot of anterior and posterior myofascial pain, and it's sort of all over, and they get this radiating pain down their arm, and it goes into their hand, maybe sometimes, or the back of the hand, not the palm, or all sorts of stuff, or they swear sometimes their hand looks blue to them. It's complicated. Especially it involves complexity, their ability to deal with their pain, and the chronicity of it, and how they interpret it. And it's just an awareness that someone may have a myriad of complex shoulder issues, and the core of it, they got a rotator cuff problem that is creating this incredible dense overlay of symptoms that if you can just sort through it, you understand how to treat it. Generally, complex symptoms reflect chronicity. I start with impingement syndrome and radiating arm symptoms, superior shoulder pain, sometimes neck pain, scapula pain dysfunction, hand symptoms, frozen shoulder. There's a myriad of things. And then they may have a whole bunch of these. Radiating pain down their arm, stiffness, neck pain, pain at night, all sorts of numbness issues, who knows? And yet the core problem has been a neglected rotator cuff tear or a rotator cuff problem. And from your perspective, from my challenge and your challenge as well, is if you can sort through that, you can, one, give the patient some reassurance that, this is not necessarily nerve damage. But I mean, I can't be 100% sure, but you can give some reassurance and say we start treating your core problem and then seeing how things unfold. Surgical treatment is best thought in terms of treat the shoulder like a mechanical part. So when things are prominent, they need to be smoothed. When things are thick, they need to be thinned. When things are torn, they need to be put back together. And when things are too tight, they need to be lengthened. That explains surgery to the shoulder for rotator cuff. It sounds simple, but it's not rocket science. It's just the shoulder. So the techniques, acromioplasty, any rotator cuff tendon surgery, be it whatever it is a supraspinatus and infraspinatus. You need to get the acromion flat. Give the cuff more space to work in. The tendons, if it's a partial tear and I'm debriding it, if there's a flap, if there's a flap, it's sticking up. It might be sticking up 3-4 millimeters. Well, there's no room for a 3-4 millimeter flap. You smooth it. The distal clavicle, removing osteophytes. Bursectomy, lice adhesions. You've got to get that bursa cleaned out. Now, bursa form anywhere in the human body where there's motion between two tissue planes. So I say, when I'm going to take out your bursa, I say, I'm going to take out as much bursa as I can humanly remove. If I can get 100%, you probably can't, but if I can get close to it, I will. So what about it? I said, it's going to reform. Because it reforms through motion and therapy. Pretty quick. The bursa forms as fast as skin heals. But the bursa should be a monolayer, 2 playing cards, thin, smooth, Teflon, not this thick, wad, gristled, fibrotic mat. But that's what subacromial cortisone injections can do. It kind of melt the bursa down some. The biceps tendon can be really involved in this as a pain generator. I'm telling you, there are a lot of times when I'm in surgery, it's a rotator cuff tendon tear, pretty straightforward, and maybe at least 40% of the time the biceps is torn as well. So if many of you are treating like my patients, you'll see where rotator cuff, if you see one of my patients with a rotator cuff repair and did not have a biceps tenodesis, that's odd. Because usually you get in there, and if it's a chronic supraspinatus tear, that biceps is going to be not happy looking. It may be torn, it may be eroded, it may be extremely tenosynovitic. Something's not right with it. And those things, biceps are wicked pain generators. And don't forget about treating frozen shoulder. Always remember that motion sets the stage for function and strengthening. So, be sure that shoulders aren't getting stiff, because many of them try to, especially diabetics. So here's the deal. You try to get that acromion flat, you got to get that bursa out, get the rotator cuff, smoothed out, and hopefully with proper therapy, everything sort of unfolds very nicely. And when we get into repairs, it's just like it's sewing cloth together. The anatomic goal is simple: to achieve a high initial fixation strength of the repair, minimize gap formation, maintains mechanical stability until it heals. Sounds simple. The problem is, from an orthopedic perspective, I'm trying to, me and my colleagues, whoever, we're trying to repair tissues that are generally biologically compromised. I'm trying to take a piece of gristle, which is what an end of a tendon feels like, sew it to a bone, and think it's going to heal. It's a complex interface. That's why a lot of rotator cuff tendons don't heal so well. That's one of the problems with rotator cuff surgery. The other problem is, at the end, if the tendon heals, great. What the patient wants is restoring shoulder function and relieving pain according to expectations. How to do that? It's physical therapy. I get it. I've got it for 20 years. And I'm always befuddled at a lot of my colleagues who underutilize physical therapy, especially for rotator cuff tendon-based problems in the shoulder. And essentially, all shoulder problems are rotator cuff tendon-based. Because restoring motion and restoring strength, I mean, I can have a tendon that maybe didn't heal all the way, or it's still weak, or the shoulder has some fatty degeneration. I mean, there's anatomic limits, there's been technical limits of what I can achieve, or in the end, my surgical experience is a little bit dissatisfying. It's not as good as I want it to be. But many times with physical therapy, they look gorgeous. 4-inch of motion, good strength, the patient's happy with it. Now, if the patient has some residual tear, they're not going to have a fully normal shoulder. But many times, as you get older, their expectations and their needs aren't as demanding. And fortunately, the predominant recreational pastime and sport in this region is golf, and golf is very nice to the shoulder. A lot of shoulders that are really not so great shoulders can play golf pretty well. I mean, if your shoulder function is great, it plays golf better. But what's challenging? Tennis. Tennis is tough. I get someone, generally, if I get someone who's had no treatment and they want to play tennis, I say, how committed are you to getting back to play tennis with that shoulder? Would you be willing at some point to moderate that activity? If they say, no, tennis is important to me, I want it. I mean, you need as close to an anatomically normal shoulder as humanly possible to play tennis vigorously and well and durably, which means I'll get MRIs early. And many times I'm offering them rotator cuff repair surgery without even trying a non-operative treatment regimen because I know they're not going to play tennis. Playing tennis with a cuff tear, I mean, then there's some examples. But if they are, they've modified. And generally the patients who play tennis their whole lives and have such wonderful stroke mechanics can do things. I mean, I saw a guy the other day who's got a cuff tear arthropathy who plays tennis every day for 2 hours. I mean, his arm goes up to here, which is kind of amazing, and he plays. He doesn't have too much pain, and I don't, but these people are the exception. They're not the rule. Generally, someone who's got a cuff tear, tennis is going to be challenging. Now, so would swimming, but not, it's not as common that people are going to be putting their head in the water and swimming freestyle, at length. Repairing the tendon is repairing two pieces of cloth together. You can do it open, you can do it arthroscopic, but also involves removing bone spurs and cleaning things out. Here's an example of the supraspinatus, and basically you take the tendon. Now, generally this tears off the bone. But the other thing is, rotator cuff tendon tears don't tear within the tendon; they tear off the bone. Who knows why that is, but that's the way it is. Just like, say, so Achilles tendon, when they rupture, they don't really rupture off the heel, off the calcaneus. They rupture around 2 to 5 centimeters above. So there's two pieces of soft tissue to put together, Achilles. Patella tendon, they can avulse one way or the other. Rotator cuff, they always come off the bone. So the weak link in the shoulder is the tendon-bone interface, which is what you're trying to restore with surgery, which is why it can be tough. How you do it, you can sew it to the bone. There's anchors that we can use. There's all sorts of things. And sometimes it's not a matter of how you do it. It's a matter that you get an anatomic repair that is secure and seems solid enough to withstand physical therapy. Because a lot of times, these tendons really going to take about 3 months for them to heal reasonably well. Back that up. So lastly, one of the big things that has changed my practice in rotator cuff is, again, I get it, the importance of physical therapy. I understand treating the shoulder like a piston engine in a car. Remove spurs, get things smooth. The notion of how to repair tendons, that's surgery, it's technique, that's experience. And after a while, I'm not repairing tendons any better than I was 4 years ago. At some point, repair is repair. I mean, you can change sutures and all that, but repair is a repair. It's getting it to heal. So the great remaining frontier of orthopedics is improving the biology. So for fractures, it's aspirating the pelvis for stem cells, and you can inject them on fractures or put them in a collagen matrix, and it works phenomenally well. I mean, I've experienced that with clavicle fractures that don't heal, but it works phenomenally well. But stem cells, which means a bony marrow aspirate, doesn't help tendons heal. It helps bones heal. The proteins that help tendons heal live on our platelets. Now, there's a bunch of them. There's half a dozen of them, but they live on our platelets. So there's these techniques of platelet-rich plasma, PRP. I'm sure you've heard about it. A lot of companies do it, and it's getting a lot of hype. Well, there's a lot of things in orthopedics that historically have got a lot of hype that fizzle. Now, I don't need to get into all those things right now. This is not one of them, in my estimation. This is real. You basically take the patient's healing capacity, concentrate 1,000-fold, put it on an area that is biologically disadvantageous, which means at some point there's a limit to how good I can repair it. There's a limit to how well you can rehab it. The help that we need to get patients happy and to reach their satisfaction is that the help we need, biology. That's the help we need. And all of a sudden, if we can manipulate biology, all of a sudden, so I'm actually preparing. I just this past about 3 months ago, I ventured at I did a rotator cuff repair in a 79-year-old. Now, of course, he looks like he's 60, but still he's 79. And the MRI said he had a big tendon tear, some atrophy, no fatty degeneration. It was one of my Pinehurst patients. Wants to be active. Exercises. Would put us all to shame every single day of the week, and he's doing great. 5 years ago, I'm not sure I wouldn't have put the patient through it. Put a 79-year-old patient through a reconstructive shoulder procedure, and 6 months later have the thing not healed. My God, and it's not just a waste of money and time. I mean, that means the surgery. There's always risk to surgery. So where's the benefit? So this is really helping, and there's a lot of companies that use it. This is one. This is what it looks like. Basically, you get off the red cells and this little gold serum. It's pretty amazing stuff. There's no graft. Historically, we would use meshes and grafts and things like that, and that doesn't work so good. And this stuff works well. 20 cc's in the patient's blood, and you see now orthopedists, which is sort of the nature of our beast, apply to everything. My God, we're injecting hamstring tears and this, that, and tennis elbow, and at some point, the dust will settle. But so many degenerative things in the body occur because the tendon doesn't have the capacity for self-repair as it had when they were 25. So if you could magically make the tendon behave like a 25-year-old tendon, all this repetitive stress wouldn't result in a tennis elbow, wouldn't result in some tendon degeneration or tearing. The tendon just sees the stress, deals with it, remodels, and keeps up with the stress. So that's what biology has done. So I'll give my last statement, and I'll turn this over to Paul for more of a rehab-intensive discussion. Then later we can talk about questions as much as you want. That the structural reattachment does not guarantee success. So this is not neurosurgery. It's not. Neurosurgeons are valuable and necessary, but they're technicians largely. Meaning, they have a patient that has neck pain, and the neck pain, they have a herniated disc, and they have X, Y, and Z pathology. They will address the pathology, do an ACDF or a cervical fusion, whatever they're going to do, and then afterward, if that neck still hurts, they just turn them over to somebody else. That's the nature of neurosurgery. Orthopedics is a little bit more clinical. If I've repaired their cuff and they still hurt, I got to figure out why they hurt. And so the tendon, the tendon must heal, but more important, the physical therapy must be complete. And I think that sort of is a useful segue into Paul's talking about PT, and then afterwards we can entertain and engage any discussion you want.
I'm going to talk a little bit about rehab of the cuff, both post-operatively and non-operatively. So both topics are pretty extensive. You could spend a lot of time talking about each. So I'm really just going to hit some highlights and be heavy on the evidence-based approach, and what's out there recently in the literature. So first we'll talk about post-operative treatment of the rotator cuff. And first, just briefly, we'll talk about arthroscopic tendon debridement. So not an arthroscopic tendon repair, but just the debridement, whether it's coupled with distal clavicle excision, chromioplasty. things like that. Basically, there's really no restrictions or precautions following this particular surgery as there are with the rotator cuff repair. So really their only restriction is lifting heavy things or keeping the weight limit down on what they're lifting. So the patient's pain level is really what's going to dictate how well they progress through or how quickly they progress through the rehab process. You can see a patient 4 or 5 days post-operatively after an arthroscopic tendon debridement and some other things involved, and they've got pretty good range of motion in their shoulder, pain maybe end range of motion. They've got a pretty short rehab stint. And you can have a patient goes through the same surgery, they come in and it's really painful, it's stiff, they're not sure what to do, and so that sort of dictates how well they progress along that plane. Following that stepwise progression in rehab of just addressing the pain, increasing range of motion, working on strength, and then getting them functional again in what they want to do in the future. So now we'll kind of go through the rotator cuff repairs, as we all know, the open procedure or arthroscopic, and I understand that the protocols from surgeon to surgeon differ, but I kind of tried to just get a general sense of what each stage reflects. So obviously, the first 3 weeks in stage 1, typically we're not going to see patients following a rotator cuff repair. They're going to be home recovering, an arm in a sling, but occasionally, if the repair isn't very extensive, we might see them a week after surgery. And at that point, it's just passive range of motion, getting early range of motion in there, not really trying to disrupt that, tear it on, and get them to that next phase. So around 3 weeks typically is when they'll come in for an evaluation. This time I think really gives the clinician a lot of insight into the recovery and how it's going to play out down the road. In the first week or two, if you've dealt with a lot of shoulders, you can really get a sense for how that shoulder in a week or two is going to respond, even down the road. Are they progressing well along that pathway, moving like you would expect them to? Are they moving a little bit ahead of schedule, and you're going to kind of need to hold back the reins in the future and not allow them to exceed those limits that are set forth by the protocol? Or are they just really, really tight? That's going to be a big thing you're going to need to address now and probably later on to the next stage. The precautions I'm sure everybody's aware of, the 40, L1, and 140. And we're also pretty limited in this stage because we're trying to protect the repair in our mobilizations. We can only do grade 2 mobilizations, which are fairly limited mobilizations. But you can help with relaxing and the muscle guarding of the patients. And oftentimes early on they're still pretty tender over the joint line, so you can't really get a great glenohumeral glide there, or a mobilization I should say, but if you move a little distally away from that painful spot, you can still get an effective glide of the glenohumeral joint that can be helpful in reducing pain and helping to increase that passive range of motion. So I think too that this is a great time to identify those compensatory patterns that patients develop following rotator cuff repair. The classic one is the scapular elevation. So if you've got them doing active assisted range of motion, whether it's supine with assistance of a cane or a bar, or whatever it is you're using to do active assisted range of motion, you can sort of detect those patterns, that shoulder elevation. And if you address that even that early, before active range of motion on land begins, you can really save yourself some time and effort later on down the road. And if you've got aquatic therapy at your clinic, I think that's a phenomenal supplement to what we do in clinic, because a lot more range of motion. They can move their shoulder, and I think more than the benefits of the range of motion and the function, but it helps to build our confidence, because a lot of times the patients will come in, and they're going through this phase. I can't even raise my arm up here. Is that normal? Shouldn't I be able to raise my arm, a little higher or a little further? And they get in the water and they see that they can do that. It's just a matter of this progression. So, as far as home exercise is concerned, the stretches that I like to give my patients, I like to be really, really, really passive, so they don't have a chance to really activate any of the muscles. So the 3 I like are supine, using a cane or a stick for external rotation, and then abduction and flexion, as this picture illustrates, either passively moving that arm with the other arm out in front of you for flexion, or out to the side with the assistance of the other arm. Or if you have a chair that rolls at home or they're at their desk, they can just plant that arm and go back or out or whatever. But really letting that shoulder relax. And a lot of times patients ask me, well, are we going to use pulleys sometime? Are we, aren't I going to get a pulley thing? Well, I'm not a big fan of pulleys, especially in this stage, because every time I've ever seen a patient use a pulley, I see this. They're doing this whole thing. That tells me two things. One, that they're using their muscles. They're engaging their muscles, so they're not completely relaxed. So they're not getting as much of a stretch as they could if their muscles were relaxed. And two, they're feeding into that compensatory pattern. They're strengthening that upper trap, and they're sending signals to it that, hey, it's okay for you to take over the work for the anterior deltoid, and the anterior deltoid never gets stronger. So if you knock that out of the way early on, again, saving your time down the road. Scapular clocks to sort of get those parascapular muscles engaged early on. Isometric internal and external rotation, again, just to get the cuff sort of mobile a little bit. And then active assistive motion, as we talked about, whether you do it in supine or, if they're doing really well, sitting, standing, that sort of thing. So in the third stage, typically they've had the follow-up with their surgeon, right? And they come to see you, and now, everything on that prescription says full, and all that stuff, so they think, all right, here we go, now we're going to get to the real stuff. But I always like to caution them about two things when they come in for that follow-up visit after seeing the surgeon. One is, focus is still going to be on range of motion. That doesn't go to the wayside. We've still got a long way to go to restore that range of motion, and that's our number one priority right now. We don't want that shoulder to get stiff. It's done great so far, or maybe it hasn't, and the range of motion is our number one priority. So isolated glenohumeral joint motion is the big thing. Scapular mobilization, and then at this time, as far as our stretches are concerned, this is where I would introduce the whole wall walking thing, right? So up to the front, out to the side, that whole business. And then with strengthening, so again, here if you haven't addressed those compensatory patterns early on, you're definitely going to see it now. So, along with advancing their stretching program, one thing I have them do when they come in for that follow-up visit after when they enter this third stage is I take them out to the gym and put them in front of the mirror, and I say, raise both arms up at the same time. And inevitably you see this whole thing going. I say, well, what do you see going on the shoulders? Well, this shoulder goes up higher. Okay. So then I use that as sort of a teachable moment to tell them why that is. The upper trap's taking over. It's a close muscle. It's strong. It's trying to do the job that it's not designed to do. It's designed to elevate the scapula, not to raise the arm up. That's the job of the anterior deltoid. So I have them actively set that shoulder down and then try and raise their arm up until they see it rise. And they say, wow, that's tough, and I can't even get my arm up that high. Great. That's what I want, because we're isolating the anterior deltoid, not letting that upper trap kick in. I always tell them quality of motion, not quantity. They're all interested in getting their arm up high, but if they do it the wrong way early on, they're never going to get that motion down the road. And then strengthening, obviously in good form once they get the range of motion back. And this is, what a lot of us do a lot of the time at this stage is strengthening, internal and external rotation, PNF patterns, both D1, D2, against resistance, rows, Ys, Ts, and arrows, and then flexion, either starting off in supine if they really don't have a great deal of flexion sitting or standing. You can just increase the resistance as they're in supine and then get them to a position where they're working against gravity a little harder once they get stronger.
What's arrows?
Pardon?
Arrows?
So Ys, Ts, and arrows are typically done over a physio ball or something. So Ys, T's, thumbs up, and arrows back here, just for lats. Same deal, standing or doing this thing. No difference. And then you get to the final stage, hopefully, and you've set this great base of support for that shoulder. You've got full range of motion, you've stabilized the cuff, you've worked on the parascapular muscles surrounding it, and now it's time to find out how well it holds up to what they want to do, whether it's back to work, whatever their activities are, recreational sports, professional sports, whatever that may be, needs to be tested out in the clinic before they go about. So you can identify, it didn't hurt before, but in my backswing I notice I'm a little restricted, or I get some pain here, or they go back to throwing it, and they come back and report these things to you. This is sort of the fun part where you get to, they go out and they try these things, and they come back and say, hey, and you think through it with the patient. You talk to them. So what is it, that you're doing? Oh, it's when I'm doing this, and it's a very collaborative, as the whole rehab process is. It's a very collaborative part. And then, lastly, in the post-operative treatment, throwing the total shoulder arthroplasty up there. So the reason I have this in here is because the protocols and the limits that we have following a total shoulder arthroplasty are not because of the prosthesis. It's because of the subscapularis that needed to be cut in order to perform the surgery and then repaired. So the prosthesis is fine. It's great. It's the cuff that has been compromised, and why we're going through the process that we do, just like with a regular open rotator cuff repair. So their recovery is really dependent upon, as Dr. Spear talked about, the viability of the tissue. Is it someone who's had severe osteoarthritis in the glenohumeral joint, but they've been working and doing everything they've done before, but just with pain? So typically their tendons are probably going to be good, viable, healthy tendons, nice and strong. So there's no reason they shouldn't get back to full, or near full range of motion, full strength. But on the other hand, if you've got someone who has had an arthritic shoulder for years, and they've really had limited use of that shoulder, and the muscles have atrophied, the tendons sort of dried up, and then you kind of don't know what you're going to get. The pain's been taken away by the placement of the prosthesis, but now let's see how much function you get back in the shoulder. So any of the rotator cuff repairs, whether it's the shoulder arthroplasty or the open or arthroscopic rotator cuff repair, it's just building that bridge, making that gap, protecting the repair, restoring full range of motion, building strength, and returning to function, and hopefully giving them some way in the future to maintain some good joint health, not only in the operative shoulder, but the opposite one as well, so they don't end up with the same problems down the road. Now, the literature in this area, post-operative rotator cuff rehabilitation, is pretty slim, relatively speaking, to the literature out there on the shoulder. But most of the stuff that's being done now is looking at how far we can push the limit with starting earlier, and getting involved sort of almost immediately after rotator cuff repair. Now, these are very small sample sizes, not really good research designs, but that's sort of where the literature right now is tending to be, is how early can we get involved without disrupting the repair. So now, maybe a little more interesting topic, the non-operative evaluation and treatment of the rotator cuff repair, or tear, I should say. So, obviously the evaluation plays a real important role. The history that they give you gives you a lot of insight into what's going on, what might be involved. Their active range of motion, you can detect any compensatory patterns if any are present. Maybe give you an indication of what particular tendon might be involved. As Dr. Spear mentioned, most oftentimes, if not all the time, it's a supraspinatus. And then also gives you a chance to look at the scapular thoracic mobility and the scapulohumeral mobility, and whether or not that's where it needs to be. And then passive range of motion, a lot of times is going to be greater than active range of motion, because you don't have that activation of the cuff or push, or the non-activation of the cuff involved, and you can stabilize that joint as you move it through the range of motion a little bit better. And this is also a great time to detect the capsular mobility of the shoulder and determine if there's any deficits, tightness, or looseness in the capsule. So we've got this great new way of measuring posterior shoulder tightness, which is one of the problems that leads to impingement and then consequently rotator cuff involvement. So Tyler et al. In 1999 first put out this new method of detecting or measuring posterior shoulder tightness. He went on then to validate this method, prove that it's a valid and reliable method for measuring posterior shoulder tightness, as well as even just this year he put out a study showing that posterior shoulder tightness, or decreasing posterior shoulder tightness in patients with shoulder pain, was directly correlated with reducing their pain. But increasing posterior shoulder mobility did not correlate directly with increased internal rotation. So, when you're looking at, treating the posterior shoulder tightness, it's not so much focusing on, as this study tells us anyhow, not so much focusing on increasing internal rotation as it is working on the posterior capsule and gaining motion out of that, whether that be through mobilizations or through, stretching out into internal rotation. But the goal shouldn't be to gain internal rotation, it should be to stretch out the posterior shoulder. So this is the evaluation method as he's described in the literature in 1999. So patient lies side-lying on the uninvolved side. The hand is underneath the head to create a level spine. Hips and knees are flexed to 45 degrees, and the clinician stands on the opposite side, stabilizing the lateral border of the scapula, and the other hand grasps the proximal end of the forearm, and then the arm is slowly lowered down until a firm end feel is felt. And then that's where the measurement is taken. Now, when he first described this measurement, it was taken from the medial epicondyle to the plinth. So that was the measure that he took to look at posterior shoulder tightness. Maury Colbert et al. At Nova Southeastern University just did a study looking at measuring it with a inclinometer, so it'd be easier to use than getting an extra hand in there, because you need another person in there to measure the distance. Strapping the inclinometer to the mid-humerus and then gaining the angle that way. And he was able to show that between the two, you need an intra-class correlational coefficient of 0.90 or better to determine that this new measuring tool, whether it's a goniometer, tape measure, or an inclinometer, is as same, if not better, than what you previously measured it with. So he showed an ICC of, I think, 0.978. So a very good, reliable method to replace this method and make it a little bit easier. Obviously, strength is a key ingredient in the evaluation. You can isolate a particular rotator cuff muscle that's involved, it's painful, weak, and then really being thorough and looking at the surrounding musculature too, not just that which affects the glenohumeral joint directly, but those surrounding it as well. And one thing to note too is that I think most of us were probably taught, it's in the textbooks, that supraspinatus is responsible for the first 15 degrees of abduction in moving the shoulder, but that really came about from 5 or 6 studies that were done in the mid to late 90s that showed increased EMG activity in the supraspinatus with abduction from 0 to 15 degrees. But what really is probably going on there is that supraspinatus is stabilizing or bringing that humeral head into the glenoid at that point, and that's why we're seeing that increased activity, and which allows the lateral deltoid then to move it. So that could be an important thing when you're evaluating strength. If you look at, oh, well, that's painful. Well, and there might be some supraspinatus involvement there too, but keeping in mind that the supraspinatus isn't responsible for that, it's actually stabilizing the cuff while the lateral deltoid is moving it. Palpation, and a special test here, the transdeltoid palpation, or the rent test. It's only really good for detecting full thickness tears in the rotator cuff, which most of us aren't probably going to be treating conservatively. But if you're taking advantage of direct access and a patient comes to you, this would be a good test to either rule in or rule out a full thickness rotator cuff tear, and then refer on appropriately. So this test demonstrates a sensitivity of 96, a specificity of 97, and a positive likelihood ratio of 32, which, if you know what those numbers mean, that's astronomical. I mean, that's just out of this world as far as statistics are concerned. That's a really good test. And then obviously just palpation of the different rotator cuff tendons with the exclusion of subscapularis, because you can't palpate. And then we've got all these special tests. I mean, these are just for rotator cuff integrity, and I don't even have them all listed here. I mean, you've got the bear hug, the modified bear hug, and all these here that have been shown in the literature. There's sensitivity has been proven, specificity, likelihood ratios. They're all good tests, but cluster signs tend to be more indicative or sensitive, specific to detecting rotator cuff tears than just one single test. So if you got an individual who's over the age of 65, has pain at night and pain with external rotation, you have a positive likelihood of 9.84 that there's a rotator cuff tear. If there's supraspinatus weakness in external rotation, and either a positive Hawkins-Kennedy or a positive Neers test, then you've got a 98% chance that there's a rotator cuff tear. So those are pretty significant. So these cluster signs are a lot more reliable than any one test that you can do to detect rotator cuff tears. And then, this is the key point, making the bridge between what you've gained in your evaluation and how you're going to approach it in your treatment. So identifying the cause. Is it age-related changes, trauma, or impingement, either internal or external impingement? And this is what I'm going to spend a little bit of time talking about now, is impingement, both internal and external impingement. So Dr. Spear already went into some of this, so I'll just touch on it briefly. But external impingement is classified sort of external as an outside of the glenohumeral joint. So the classic impingement, outlet impingement, Neers impingement as it's described by Neer, and that's just the superior migration of the humeral head, pinching those structures underneath the acromion there. Presentation, as Dr. Spear mentioned, typically pain anterior, laterally, things of that nature. And then internal impingement, internal meaning within the glenohumeral joint itself. Now, in this issue of the British Journal of Sports Medicine, there's two really good articles on internal and external impingement. One's a literature review, pretty extensive, and the other one's an actual study. So some of the theories behind what's causing this internal impingement, one is a tight posterior capsule, as we talked about how to measure that early on. I put that in there because that's a really important thing to look at, specifically when talking about internal impingement. And this is really seen a lot in baseball pitchers. That late cocking phase, they get pain posterior and say, it really hurts when I get back here. Well, the thought process behind that is that you need a lot of force to decelerate that arm as you're coming through and your follow through. So that creates some trauma to the posterior shoulder, eventually leads to scarring down the posterior shoulder and tightening of that posterior shoulder capsule. So then that tightening of that capsule then pushes that humeral head anteriorly, maybe superior a little bit, and demonstrate a little bit of laxity in the anterior capsule. So you get this compression of the supraspinatus, maybe even the infraspinatus, in that posterior superior glenoid rim as it rotates into external rotation at 90 degrees of abduction. And you can also get involvement of the posterior superior labrum with this as well. So in this little schematic here, you've got the shoulder abducted and externally rotated to 90 degrees, and the impingement that is occurring is right in through here. So you get that posterior capsule back behind here pushing it forward, which gives a little bit of space, so when it rotates, it pinches in there and causes pain, potentially could cause a tear. So typically the presentation with this is, my shoulder hurts back in here. Now it could be a diffuse pain as well, but detecting the differences of why that shoulder hurts and what's impinging it and what structures are tight and weak is a really key point into how you're going to apply your treatment approach. Because, really if there's any involvement in the rotator cuff and you strengthen it, it's going to feel better. But is it going to last if you don't address the appropriate things at that point? Probably not. So then your treatment strategies are based on what you found there and identified as being the culprit. So you target the weak musculature that you found on exam, strengthen it, strengthen the supporting musculature, the cuff, the lat, the rhomboids, anything that might be weak, or just to help support the scapula and the glenohumeral joint. And obviously we want to work these muscles or the shoulder in a way that's not painful, because if it's painful, chances are you're causing further impingement, further damage. So maybe that means working through a less range of motion or working those muscles eccentrically, whatever that might be. Then restoring the force couple, so not just focusing on the glenohumeral joint, but also addressing the muscles as they try and maintain that scapular position on the thoracic spine as it moves through the motion. And then as far as their exercises at home, stretching out that posterior capsule, whether it's cross arm test or the towel stretch behind the arm or the sleeper stretch, none of which have been studied in the literature currently to detect which one's more effective than another. But hopefully with this new method of measuring posterior shoulder tightness, you might start to see more studies out there determining which one is more effective as far as home goes to get the increased mobility in the posterior capsule. So mobilizations, what we can do in the clinic, mobilizations in combination with exercise in literature have been shown to have superior outcomes over any other treatment. Exercise alone, mobilization alone, combining the mobilizations with exercise is superior, particularly if there's tightness in that posterior capsule, as we mentioned. So, your glides anterior to posterior, inferior glenohumeral joint glides. Posterior to anterior, probably not in this case because you potentially already have a lax anterior capsule. So you're not going to want to stretch it out anymore because that's going to cause further problems down the road. But, post-operatively at the appropriate time after a rotator cuff repair, those are appropriate. So just some diagrams here. This is a general anterior posterior mobilization. Typically hands would be flipped around, but for the camera view, so my back would be facing you instead, and the left hand would be performing the mobilization. This is more my preferred method, and it's the one that's been shown to be more effective at increasing posterior shoulder mobility. I like this because you can stabilize or get a sense with that left hand where that humeral head is and where you're providing this mobilization. So if depending on what part you're trying to mobilize, you can really get a feel where that humeral head is when you're doing that. So that feedback really helps me in addressing the spot that I want to address. And then this little arrow here indicates you can sort of preset before you do that mobilization a little inferior glide, create some more space in there. It's more comfortable for the patient and can be more effective too. So just a little inferior glide, and then your anterior to posterior mobilization is a lot more effective, because essentially what you're doing is you almost put them in a Hawkins-Kennedy position, which should be reproducing pain without this. So not so much elevation, and then that inferior glide can help reduce the pain and still be effective. Again, posterior to anterior mobilization, probably wouldn't be doing this one on someone with shoulder problems unless it's post-operative and they've got a lot of anterior tightness. I don't like this because it doesn't take a whole lot of force to move that glenoid too far with that. This one, however, this posterior to anterior mobilization has been proven in the literature to help reduce pain in individuals who have shoulder pain and also be effective at mobilizing the shoulder. So again, the way this is proven in the literature to be effective is first with a little bit of an inferior glide and then posterior to anterior, sort of all at the same time. And that can be an effective way to reduce pain. It doesn't provide you a great deal of force to provide your mobilizations, but it can be helpful in reducing pain. And then inferior mobilizations to increase flexion of the shoulder. And again, force just driven inferiorly. Scapular mobilizations. There's a lot of different positions, ways to mobilize the scapula, but in this position they're side lying on the opposite, the uninvolved arm. Again, maintaining an aligned spine, hopefully, and then the patient's opposite arm, so they can relax, is either resting on the clinician's hip or the thumb is back through the belt loop, so that shoulder can really relax and they can feel supported while you're doing that mobilization. So, next topic is a particular interest of mine, and that's cervical thoracic mobility, or the use of thrust manipulations of the cervical thoracic spine in reducing shoulder pain. Now, by no means am I trying to teach anyone here shoulder manipulation, but for those of you who've been trained to do it, who use it, or at least trained to do it, just kind of as a review. And I bring it up because it's a very hot topic in the literature recently. So Boyles et al. Were the first ones to put forth a study sort of linking the cervical thoracic thrust manipulations to decreasing shoulder pain. So he was able to find that cervical thoracic thrust manipulations were effective in reducing patients' perceived pain following the treatment, but not a great study. Not a randomized controlled trial, just a one group pre-test post-test study, which doesn't allow for a great deal of generalizability to what you can do in the clinic. And then this year in January, in Phys Ther, Minkin and Cleland et al. Did a study again looking at cervical thoracic manipulations in patients with shoulder pain. And he was looking at reducing pain and then finding predictive factors that might be indicative of patients having a good outcome. So he's looking at developing a clinical prediction rule for individuals that would benefit from cervical thoracic manipulation and reducing shoulder pain. So what he found was that if 5 variables were present, if they had less than 127 degrees of pain-free flexion, less than 55 degrees of internal rotation, painful symptoms for less than 90 days, on no pain medications for the shoulder, and a negative NIRS test, that there was a 100% post-test satisfaction for reducing pain as measured in their study. Now, if only any 3 of those were present, it dropped to like 89%, but still pretty good outcomes. Now, that's just short term. If you're trained to do manipulations or done manipulations, it's not going to cure the problem. It's not the way to fix the problem, but it can help reduce the pain, make it more manageable, and maybe produce a little bit more range of motion, which some procedures have been proven to study. Again, not something to change the way you practice on. It was a single-arm trial in reference to the research method, so no control group. There was just a patient population, so not a randomized control trial. And without that, you can't make any inference between the treatment and the outcomes because there's nothing to compare it to. So, hopefully there's going to be some research soon to be a little bit better and something that we might be able to do to help reduce shoulder pain. So, again, just to review some of the manipulations that they performed in this study that were shown to be effective. And this particular manipulation has also been shown effective to increase shoulder flexion. So it's called the pistol manipulation. It's called that because of the grip that you use. You form a pistol grip it would be this hand here, and spinous process aligned between the thenar eminence and these fingers here, and just above the third finger is the segment in which you're interested in manipulating. So it's not a general manipulation, it's a very specific manipulation to the stiff or concordant segment. You can't see my hand here, but it's paying particular attention to keeping the neck and cervical thoracic spine in flexion as you perform this manipulation. And the thrust is done through the clinician's sternum directly through the shaft of the humerus. The distraction manipulation of the upper thoracic segments. The previous one, the pistol manipulation, is also for the upper thoracic spine, not the mid or lower thoracic. So patient long sitting, neck in flexion, hands behind their head, laced fingers, and the clinician places their arms up around the patient's hands in overlapping hand position, and the sternum is directly in contact with the thoracic spine. You can attempt to manipulate a specific segment by rolling up a towel, placing it on your sternum, and keeping the high level of the towel just below the segment that you're interested in manipulating, similar to the pistol manipulation, the placement there of the segment. But this is almost more of a general manipulation than a specific manipulation. And then the thrust is indicated to anterior and superior, paying particular attention to keep the neck and cervical thoracic spine in flexion, not allowing it. The potential, a lot of times what you see people doing is sort of this whole thing where you're kind of scooping up and back. It should be up and forward, which takes a little practice getting used to. And then the screw manipulation, and its name comes from sort of the latter part of the manipulation, using a pisiform grip. So the pisiform of both hands is on the transverse process of the segment you're trying to manipulate, and then the opposite pisiform is on the contralateral above or below segment that you're trying to manipulate. So one pisiform on one, whether it be the left side, and then another one up above. And this is all based on your evaluation prior to doing this, identifying the concordant segment and which one might be stiff or might need to be manipulated. And then the patient's asked to inhale and exhale normally. And the screw part of the screw manipulation is that you sort of wind up or take up the slack in the soft tissue as you're moving down, and as the full breath is exhaled, that's when the force is then applied. So you take up the slack and then perform the manipulation. Other treatment methods, modalities, ultrasound. I use it sparingly, sort of patient dependent, because it's not really proven to be a great way to reduce pain or increase soft tissue extensibility or anything like that in the literature. It was just January in Phys Ther, they specifically looked at ultrasound's effect on soft tissue in the shoulder, and it was a literature review, so they gathered I don't know how many hundreds of studies, and they boiled down to only 8 that had semi-credible research designs and sampling methods and things like that. They couldn't even perform so when you do a literature review, the goal would be to perform a meta-analysis. That's the highest level of evidence you can put out there. But in order to do that, the study designs of the research that you're reviewing has to be at a certain level. And most of this literature was not at that level. So they're left with 8 studies, and I think 3 produced positive outcomes, 2 said there was no difference, and in the 3 that did produce positive outcomes, they were more involved with calcifications of the tendons, so it might be effective with that, but in reducing pain or increasing tissue extensibility, not so much. And then on to apheresis. Some people use it, some people don't. If it's really painful, irritated, inflamed, it can be effective in decreasing pain. And then the old heat and ice. So whichever one feels good, right? Takes your mind off the pain. And then the ultimate goal is same as post-op and same in any case with rehab, is to get back to those functional activities, work-related activities, or return to sport, making sure that they don't fall back into those patterns, or they might have different patterns in the sport or activity that they're doing that didn't present themselves in clinic until they went out and tried to do it. And then you address those, trying to have them reproduce that in the clinic, and even create exercises that sort of mimic those specific things that you're not going to find in a VHI catalog to print pictures of, but things that you make up with the patient that are specific to them and their needs and what it is that they're limited in or weak in, related to their functional activity or their sport. So you also want to leave them with some sort of maintenance program, if you will, following their stint there, because your hopes are that they don't fall back into the same pattern that they did before. So say they've got a bone spur and the cuff's weak and you're getting that impingement and the bone spur is digging into something. You strengthen the cuff, you realign, you restore that force couple in there. Everything's great. Bone spur's still there. So they go out, they don't do their exercises, they come back, my shoulder still hurts. Have you been doing your exercises? No, I felt better, right? So educating them about the importance of that, and also addressing things early on in the examination that dictate the treatment, and not just, it's a rotator cuff tear, rotator cuff pathology, we're going to do this mobilization, strengthen this, stretch that, but really being picky early on in the examination, spending the time to find out what's going on and then addressing it appropriately. That's it. So references, thank everybody for coming out.